Hi, everyone. Welcome to the fourth in our series of RReSTORe virtual discussions. I'm very excited today to introduce you to Professor Roger Barker. If you don't know him already, he's at the leading edge of stem cell therapy as it pertains to the treatment of Parkinson's disease. And I thought that this would be a great opportunity for us to learn more about what has transpired and what's worked and what the challenges have been in a field that admittedly is further along than retinal ganglion cell replacement is. Parkinson's disease cell transplantation has been under preclinical investigation for many years now, and as Dr. Barker will tell us, is now at the stage of human clinical trial. They've made that translation from bench to bedside, and while there's still a lot of work to be done, I think this is a real testament to the work and success that can come from large-scale collaborative endeavors aiming to treat neurodegenerative disease with cell therapy. Like all of our virtual discussions, the plan is for Dr. Barker to start off with maybe a half an hour, 45 minutes of some background information telling us about the journey that his field has taken to get to this stage. And then after that, we'll leave about 45 minutes for group discussion where we can do questions and answers and try to take the most salient points from the conversation and think about how we can use those experiences and ideas to foster collaborative efforts to move our own field of retinal ganglion cell replacement forward. So with that, I will stop the screen share and ask Dr. Barker to take it away.
Well, thank you very much. I think that is that up in proper? Is that?
Yep, there we go. Full screen. That looks perfect.
Okay, so thank you very much, Tom. I have just changed the title very slightly.
Sure.
So I removed the word success. Because it's successfully translated, but whether it successfully works is yet to be decided. So I thought I would just have it learn from this translational story. So I thought what I would do is I would introduce you a little bit to what Parkinson's is, the rationale for it, and I'm going to take you through the sort of history of this field, which is about 40 odd years old. So it's a much older field than people perhaps realize. So the first question, I suppose, where we need to start is, what is Parkinson's? And I'm sure a lot of you are very familiar with this. So for our discussion today, it is a clinical diagnosis. And as I go through, I try and highlight various points. So that creates a little bit of a problem in our trials, because we have to make the assumption that people have Parkinson's based on their clinical characteristics. We have no diagnostic test. But essentially, people who look as though they've got Parkinson's with this resting pill rolling tremor, some stiffness, slowness, bit of problems with walking, and a response to medication, about 95 to 99% of those will have Parkinson's disease. But we can't be certain, and that does create some problems when you're designing trials, because there is the potential that some of your patients don't actually have the condition which you think they have. So clinically, Parkinson's looks like this. Pathologically, it's defined by the loss of a very discrete population of neurons which project from the upper brainstem in the substantia nigra up into the putamen. And in the human, there are about 400,000 on either side of the brain. And when you've lost 200,000 of those, you develop the first clinical features of motor Parkinson's disease. Ergo, if you can replace 200,000 dopamine cells of the right type, you should, in essence, put people back to normal. So that's the clinical definition. That's the pathological substrate for that. And we know that that pathway, that loss of that dopaminergic nigrostriatal pathway, is critical to the expression for the disease, because for 50 years and more, we have used that as the basis for our treatment. So the current treatment of Parkinson's in the clinic is you use either enzyme inhibitors to increase the amount of dopamine in your brain. You replace the dopamine with L-DOPA. You stimulate the dopamine receptors with dopamine agonists or apomorphine infusions. And then you basically treat the complications of that therapy with amantadine to get rid of some of the involuntary movements that the drugs drive, and deep brain stimulation to try and correct the networks which are giving you abnormal movements. So essentially, the entire treatment of Parkinson's in 2023 is around restoring that nigrostriatal pathway and dealing with the complications that result from it. And so when we come on to talk about how we're going to repair the brain in Parkinson's disease, what am I actually hoping to achieve? It's important, first of all, to realize that the pathology of Parkinson's is much more extensive than just the nigrostriatal pathway. And this is quite a famous picture. All the red is the ascending pathology you see in Parkinson's disease. And so the earliest features begin in the lower brainstem and then project up and out into the cortex. So actually nigral loss is stage 3. But nevertheless, as I say, that is known to be the critical pathology, and that is what we're trying to repair. So we're quite realistic about what we're trying to do. We're trying to put that pathway back to normal. And when it comes to your own work, I think it's important to understand which bit of the network am I actually trying to repair. Does the disease only localize to that area? In which case, is my therapy only dealing with one aspect of it? And I think it's important because you then have to answer the question, well, what does this actually mean for patients with Parkinson's disease? If we got this to work and we could actually get this to achieve the success that I'm going to come on to talk about, then what would it treat in Parkinson's disease? Well, obviously what it would treat is it would treat all the things that we can currently treat in the clinic with dopamine drugs. So it would be as good as the best response to the medication we have at the moment, which then sets up some competitive questions about what is the point of pursuing this if you actually are only trying to achieve what you can do in the clinic at the present time. But the important point, and there are a number of important points about this whole strategy. The first is if it worked and it worked consistently and it worked very well, then the treatment of Parkinson's disease would be radically simplified into a single one-off treatment to repair the dopaminergic nigrostriatal pathway. That would therefore get rid of all the need to use any of the drugs we do at the moment, plus all the complications. So in essence, it would transform the treatment of Parkinson's disease going forward. It would also, because we know from studies where people have given patients dopamine in the on-off state, so this experiment is you take someone with Parkinson's disease, you look at the connectivity in the brain before and after they take dopamine, and what you find is that the dopamine isn't just replaced at the site where you need it, but it also normalizes network flow through the structure where dopamine is put back, namely through the striatum. So it will normalize that circuit. So when it just replace what's missing, it will actually normalize the output from that circuit, which obviously mediates its clinical benefit. So why would I want to do that instead of just using the drugs I use at the moment? Well, obviously, it's a one-off treatment, which has various advantages. It also has primary advantages over the treatments we use at the moment. First of all, the therapy would only target the area which is lost. Dopamine is lost. That could be a limitation of it, but it's also an advantage because obviously all the oral medications stimulate dopaminergic networks, which are largely intact, and that drives some of the cognitive problems that you see in Parkinson's. It drives some of the neuropsychiatric problems that you see in Parkinson's, and it exacerbates some of the other problems, such as the autonomic problems around postural hypotension. So it would avoid all the off-target effects, and it would also avoid all the long-term complications you see with the oral medication, especially L-DOPA, where you get these genesis of these involuntary movements after people have been on this medication for a number of years, these so-called on-off phenomena and dyskinesias. This treatment would avoid that. So it would transform what we could do in the treatment of the patient, but it's also important to understand what it won't do. And I think this is important because in this field, as you know as well as I do, there are many extravagant claims made about these type of therapies. Quite obviously, I'm only repairing the nigrostriatal dopaminergic network. So anything that lies outside of that, any other network, any other dopaminergic system, as well as all the other pathology you see in Parkinson's, which underlies a lot of these other features of Parkinson's, will not be helped by this treatment. So I will not be treating the autonomic problems. I will not be treating the cholinergic deficits underlying some of the gait disorders and cognitive problems. I may be ameliorating some of the problems you see with that by reducing the medication that they normally take orally, but I will not be treating those aspects of it. And I will certainly not be curing this condition. Now, it may be different in your area, but the primary problem in Parkinson's is the accumulation of a pathogenic protein within cells, alpha-synuclein. I am not targeting alpha-synuclein. I am not dealing with the fundamental pathological pathway. So I will never cure anyone with this therapy. Having said that, it is a disease-modifying therapy in the sense that before L-DOPA was used in the 1960s, your life expectancy with Parkinson's was probably about 10 years. Before the motor symptoms and motor signs would overwhelm the patient, they would die, typically of aspiration, typically of pneumonias. Whereas once symptomatic therapy came along, they obviously live actually normal lives, most people with Parkinson's, in terms of life expectancy. And the same is true of asthma. You very rarely cure people of asthma, but you can control them very well symptomatically. So good symptomatic therapy, whilst not being disease modifying and curing, nevertheless can have a dramatic effect on the natural history of this condition. And obviously, because this is an intervention where I'm putting something into the brain, into a specific site, there's no reason it couldn't be used with other disease modifying therapies, such as cocktails of drugs designed to get at the basis of the sort of pathological aspects of Parkinson's. So it's not mutually exclusive. It isn't you either have this or you have a disease modifying therapy in the traditional sense. You could actually have the two together. And finally, it's important to realize it won't be suitable for all patients. Average age to get Parkinson's is 70, so there'll be a lot of people in their 80s who respond quite nicely to medication, have a life expectancy of only a relatively short period of time, for which this type of intervention would not be suitable. If you have patients who don't respond to dopamine drugs for whatever reason, they won't benefit from this therapy. So I think it's also important to be realistic that it's not suitable for everybody, but one would hope that it's suitable for enough people to make it economically viable for the investment that's needed to take this into the clinic. So then how could you repair this pathway? How could I put the nigrostriatal pathway back to normal? Well, obviously, one way is to repair it from within. You could enhance the neurogenic process underlying the production of new midbrain dopamine cells, which would be great, except that doesn't happen in the adult human brain as far as we know. You can make dopamine neurons in situ, and I'll come back to the end, the idea of in situ reprogramming. And there's obviously been a great deal of interest in the use of growth factors to try and stimulate the survival and growth of those remaining dopamine cells in people with Parkinson's, which has had a very checkered history. And I'm not going to talk about that today, but happy to discuss it later. The more obvious way, and what I'm going to concentrate on today, is repair from without. In other words, just replace what's missing. So the strategy here is obviously quite straightforward. I'm just going to replace the lost dopaminergic neurons, which lie at the heart of Parkinson's disease, and which I target with my oral therapies, with a new set of fresh midbrain nigral dopamine cells. And they have to be of the midbrain type, and ideally of the A9 nigral, of the type specifically lost in Parkinson's, because there's a lot of experimental work showing that actually if you use cells which do not have those characteristics, they do not work as well as those which are lost in Parkinson's, i.e. the nigral A9 neurons. So that is what we're going to concentrate on. So we want to repair the brain by transplanting in a population of dopamine cells, of which 200,000 will survive and differentiate into the midbrain dopamine cells of the type lost in Parkinson's disease. So then the question is, well, what could I use for that? What could I actually use to replace those cells? So one place, and which this is where the field was, particularly in the 1980s, was to go hunting around the body and find a dopamine-rich source in the patient themselves, and then do autologous grafting. And the two areas where people got particularly interested were the adrenal medulla, obviously the adrenal gland next to the kidney, the medulla, which produces obviously a lot of adrenaline and noradrenaline, not very much in the way dopamine was chosen, and the carotid body, which obviously sits next to the carotid artery, senses oxygen, contains dopamine cells. And these have been the subject of rather limited preclinical work with limited efficacy and survival, but nevertheless translated into the clinic and essentially were shown not to work. And I'll just briefly mention that in a minute. An alternative is to use the developing dopamine cells from the human fetus. So this would involve the collection of fetuses from termination of pregnancies, from abortions, dissecting out the developing dopamine cells from the midbrain of that fetus, and then transplanting those into the adult Parkinsonian brain. And then obviously more recently, since 1998, and the first human ES cells were derived, you could use a human embryonic stem cell from an IVF program, or you could, since 2007, use a reprogrammed somatic cell into an iPS cell, which can then be driven into a dopamine cell of the type that one wants. So obviously there are many different sources one can use, and as I've said, essentially these adult sources which were autologously transplanted were very much the fashion in the 80s and the early part of the 1990s, and were shown not to work. Preclinically, the evidence was quite clear that these had a very modest effect, if any. The survival was very poor, and when it came to patients, that was recapitulated. There were very few surviving cells in those that came to post-mortem. The clinical benefits were minimal and very transient, and the morbidity associated with the intervention was quite substantial. So essentially, this idea has essentially disappeared, although the use of adult cells and making iPS cells from patients as well as from unaffected individuals has gained prominence of late, and I'll come back to that. But the area that received the most attention and which underpins the entire field starts with the use of fetal dopamine cells. So as I say, this is not an ethically neutral area, especially in the United States, where this will require human fetal material. But this work, which obviously began preclinically in rats and essentially originated in Lund in Sweden with Anders Bjorklund and his team, and was then translated into the clinic by Ulla Lindvall, his clinical colleague. And essentially what this demonstrated, and this was preclinical work which took place over about an 8-year period but was replicated in many other labs, was they essentially used a very simple model. So they lesioned the nigral striatal pathway, projecting up through the medial forebrain bundle. And they did this with a toxin, classically 6-hydroxydopamine. Now, people say, well, this is not Parkinson's disease, so this is a useless model. And I would entirely agree this is not Parkinson's disease, and it's a useless model of Parkinson's disease. But what I'm interested in is not treating Parkinson's disease. I'm interested in treating the dopamine loss of the nigrostriatal pathway. So as long as I have a model that that captures that loss of that pathway, it's perfectly good for the system that I wish to test, which in this case is restoration of dopamine into the denervated striatum, which is where the cells are placed. And it's important to realize that essentially all of the success that's happened in this field has not derived from transplanting the cells into the substantia nigra and having them grow up into the striatum, but is placing the cells where their dopamine is needed, which is in the striatum or the caudate and the putamen. And so over an 8-year period, there were essentially this lesion, which was developed in the 1970s. Subsequently, other models have been developed, transgenic models, the use of alpha-synuclein preformed fibrils to replicate more that takes place in Parkinson's disease. But fundamentally, if you knock out the dopamine system, that's what you're after. You then want to monitor the deficits, which in animals is very easily done with drug-induced rotation. You can do cognitive testing, you transplant your cells in, you monitor the deficits to see if they recover, and then at the end you sacrifice and do your histology. So that's very standard for all of these types of work. And what was shown over this period of time, and this is a transplant from my PhD in the Dark Ages, was that actually this is the striatum. So in the rat, you don't have caudate and putamen split by the internal capsules you do in humans. It's just one structure. But this brown sausage here is fetal dopamine cells from a rat fetus, so embryonic day 14, transplanted into the adult rat. All of the brown you see around these are the fibers that are grown out, and on the outside of this transplant are all of the surviving dopamine cells. And so what was shown, as I say, over about a 10-year period and consistently between labs, was that if you used allografted tissue, i.e. rat to rat, it survived long term, which in a rodent was 6 months to a year. That if you dissected out the developing midbrain from these fetuses, so the ventral midbrain, they differentiated into the dopamine cells of the type which you'd find in the adults of midbrain. It was shown through the limited tracing studies that were available in the 1980s that these transplants could make and receive connections from the host. So they didn't just sit there and pump out dopamine, they made some sort of synaptic network, that they released dopamine, that they restored many of the behaviors you induce in these animals with these unilateral lesions, but not all of them. But you could restore some of the critical ones, and it was reproducibly done in many labs. And so it was shown to be a consistent and robust effect. So this then led in the late 1980s to a whole series of trials which ran through a series of open label studies, mainly done in Sweden, in Lund, but they were also done in Paris. They were done in Halifax, Nova Scotia, and they were done in Denver by Kurt Fried, as well as other sites. So there were a number of centers that undertook this approach, which, as I say, in the case of humans, involves collecting tissue from human fetal material, typically 6 to 8 weeks post-conception. You dissect out the developing midbrain and you transplant it in. And in order to ensure that you have enough surviving dopamine cells after that procedure, you typically need, I would say, to transplant in at least material from 3 to 4 fetuses per side of the brain. And what we found over this period of time in the open label studies, that the results were very inconsistent, but when it works extremely well. So these are 2 patients who were followed up in London, who received their transplants in Sweden. And on this picture here, what one can see is that essentially they had had Parkinson's disease for 10 years before they were grafted. So both these patients had Parkinson's disease for 10 years. And here you can see at about 20 years post-transplantation that their scores have improved. So the UPDRS here on the y-axis is the higher you are, the worse you are. And you can see that these patients drop down to about 20, which is about the score you probably have by the time you actually present to your neurologist in the first place. And that was remained consistent over a 20-year period. Took about 5 years for the maximum benefit to be seen. And this was in the face of them stopping all of their medication. So in these 2 patients, 30 years after diagnosis, they were on no medication. They had a UPDRS score that was probably less than when they first presented. And on their PET scan, looking at dopamine in their brain, it was essentially normalized. So this was a proof of concept that you could get long-term clinical benefits. This was patient number 4 in Sweden who had a unilateral transplant. He derived similar benefits, came off all of his medication, but eventually succumbed to a dementia with Parkinson's disease many years later. This is his post-mortem 24 years after receiving the transplant, 30 odd years into his Parkinson's disease. He had a non-grafted side, so he had a transplant on one side. This is stained for dopamine fibers with TH, absolutely nothing. And everything you see through these sections are surviving dopamine cells in innervation of the Parkinsonian putamen. So there was clear evidence that in some cases, these transplants could survive long-term, both clinically on PET and at post-mortem. The results were somewhat inconsistent, but what slightly derailed the field were these 2 NIH-funded studies, which began in 1992 when Clinton came into the White House and allowed federal funding for the use of human fetal material. So in this first study, which was published in the New England Journal in 2001, there were 40 patients in this study. 20 were randomized to have a transplant and 20 were randomized to have sham surgery. They were followed up for a year. At the end of a year, they were asked how they felt. Those who had the transplant felt no different to those who had not had the transplant. The non-grafted group were actually offered a transplant. So ultimately, 33 of these patients had a transplant. So if you look over the first 12 months, which obviously is a short period of time, there was no significant benefit from having a transplant versus sham surgery, although you can see the patients were much more advanced than those in the Swedish study, and that there is clearly a downslope with the transplant, but not the non-transplanted. So there was no significant benefit, but what was slightly worrying was that 15%, so 5 out of the 33 patients who eventually had a transplant, developed these involuntary movements, these dyskinesias, in the absence of medication and the presence of a transplant, which created some concern because obviously you can't get the transplant back. So there were side effects which were now appearing, which had not been seen previously in the context of a trial that had shown no benefit from the therapy at a time when deep brain stimulation was becoming much more favored as a treatment for people with advancing Parkinson's disease. The second NIH study was then published 2 years later. In this study, there were 34 patients. A third of them received imitation surgery. A third received a small transplant, and a third received transplant from 4 fetuses. The smaller one was from 1 fetus. And what they found was that whilst there was some evidence of graft survival, on imaging, whilst there was a significant benefit for improvement in those who had had the transplant, clinically, there was no significant difference between these patients. They all had immunotherapy of cyclosporin for 6 months after this, as opposed to the previous study where there was no immunotherapy that was given at all. But worrying in this study was the fact that now 54% of the patients had developed dyskinesias in the presence of a transplant when off medication. So here was a second trial that showed that there was no significant benefit in what was thought to be a more rigorous approach, because it was a double-blind, placebo-controlled trial, showing that the transplants in both trials had not significantly improved the patients at 1 and 2 years, and significant side effects were seen in 15 to 54% of patients. So in 2003, this field was essentially announced to have had its day, and it was no longer a viable option. Now, this obviously could be a very sensible conclusion to come to, but we sought to sort of reevaluate this on the grounds that whilst these double-blind placebo-controlled trials had produced negative outcomes around their primary outcome, there was nevertheless clearly trends that could be seen in it. And we had these open label studies where there were definite benefits in individual patients. So we set about doing a meta-analysis of all of the studies that had had patients recruited, that they had sort of as rigorously as possible followed up for 2 years. And we did various analyses as best we could with the limited data. And essentially what we found was that if you plot all the data, so this here is the change in the UPDRS, so that's getting worse, that's getting better. This is 2 years post-transplantation. About a third of the patients had a good response, by which we mean a greater than 20% improvement in their off score, i.e. when they're not taking medication. So their sort of baseline score implying that they're better. So about a third of patients seem to have a good clinical response, but 2/3 didn't. So obviously for this to become a therapy outside of the ethics, you have a problem in that every 3 patients I take to the operating theatre to use this therapy, only 1 will improve, which is clearly not competitive. So one of the things we tried to do is we tried to analyse these trials to see if we could work out what were the characteristics of those patients who responded best to that intervention. And essentially what we found was that it was younger, less advanced patients, so patients earlier in their disease journey who were younger, typically under the age of 60, those in which there'd been more rigorous tissue prep and sufficient tissue used. So we would say that you needed at least 3 ventral mesencaphalons, so 3 fetuses per side in order to stand a chance of getting the right number of dopamine cells in. We felt that those had the best response had been those trials where immunosuppression had been used, and the absence of immunosuppression, whilst not stopping transplants from surviving, definitely seemed to compromise their clinical benefits and their survival. And as I've already intimated, longer follow-up seems to be an important factor, because in those most successful open label studies, it was at least 5 years before you saw a clinical benefit. So we took this information to the European Union, who very bravely funded us to do a study called TransEuro. So that's what the FP7 grant was from the European Union. And essentially this had 2 major elements to it. One was we set about trying to show that we could select patients who we thought were optimal for this intervention. So part of the reason why patients had not had such variable outcomes in the previous trials was we hadn't thought enough about who were the ideal patients. And we said we thought the ideal patients, as we've already said, were younger patients earlier in their disease course who did not have significant dyskinesias relating to their oral medication, who were cognitively normal. And so we wanted to show that if we followed that cohort of patients up over a period of time, they would not develop dyskinesias, they would progress, but they wouldn't progress aggressively. So that was part of the study, was the natural history study. Could we better select the patients who might be suitable for this? And then the second part of it was a transplant study, where we would optimize the delivery of the tissue, at least 3 fetuses per side, delivered with a device which we knew worked based on previous work from Sweden. And in the initial iteration, we were going to do an open label transplant study in 20 patients. I mean, this was super optimistic. And then on the back of that, we would have sufficient data to go and do a double-blind randomized controlled trial with match funding for a US arm, which would complement what we were doing in Europe, which we felt would be a more definitive study. So just in terms of the natural history study, I would say that we did demonstrate that this patient selection that we had fitted in more what we thought. So paying attention to the patients was important. These are quite hard to see, but essentially over the first 3 years, they were in this natural history observational study. They progressed with their Parkinson's in a linear fashion. This, the Annenberg's cognitive examination, you have to get less than 84 to be demented. They were entirely normal. The dyskinesia scores can be up to 4. They were not developing dyskinesias, and they progressed in a fairly linear fashion. So we felt the patient selection was appropriate, and the design of this study was, rather than have sham surgery or placebo, was that out of the 100 patients or so, we would randomly select the patients for the open label study, who would then have the intervention. A subgroup of the natural history study would also have PET imaging. So ultimately, we could compare our intervention against a control arm, the control arm being those who'd been in exactly the same assessment period over a prolonged period of time, who had also had PET imaging, but they hadn't had any other intervention. So they were a contemporaneous natural history control, not historical, contemporaneous. So we thought this would be quite a good way of actually being able to assess what happened with our patients. So ultimately, whilst the natural history study was very encouraging, the actual transplant study proved to be much more difficult than we ever envisaged. And at the end of a 11-year period, we had ended up doing one incomplete trial where we had grafted 11 patients, 10 bilaterally and 1 unilaterally. And I'll come back to why we had such problems grafting, why we grafted so few patients. So what did it show, the transplant study? Well, the sort of take-home figure is it didn't really work in the way that we expected. So one of the advantages of the trial design that we had is that we had a long run-in. So by virtue of what you'll see in a couple of slides' time, all the problems we had in this trial, the first patient was grafted in 2015. So we had patients who had been followed up for at least 4 years before we had an intervention. And in fact, some of these patients have now been followed up for 8 years post transplantation. So we have a long run-in period and we have a long post-operative follow-up period. And I would strongly recommend this as a way of by which to assess what your therapy is doing. Maybe different in eyes, but certainly in these chronic, slowly progressive degenerative disorders, it's quite helpful. So in this slide at the top, we have a control group here. This control group is the remainder of the study, the remainder of the patients we had in the group who did not have any intervention, but were followed up with the same assessments, who went on to also having PET imaging. And what you can see, as you would predict, is over this period of time, which is like a 7-year period, the control group, as I've already said in the previous slide, get progressively worse. The transplant group essentially get worse in exactly the same way. They then receive their staged transplants, which makes analysis a bit difficult. But over time, you can see that whilst the control group have got progressively worse, these seem to have stabilized. Now, of course, could be placebo effect, could be investigative bias, but it looks quite convincing that something has happened around the intervention where the patients have stabilized. Now, there were a couple of other issues with this trial. One is that we discovered, just as we were about to transplant our first patient, that the hospital here would not insure the device which we had, which we were using, which was made in-house in Lund. So the transplant device is made in the hospital in Lund. We've used it previously at the Annenberg's Hospital in Cambridge for a previous transplant trial in Huntington's disease, but here they said it was not insured, so they built a matching device. And the one thing I can say is that while superficially it may have looked the same, it did not behave the same. So this is the device that was used in Sweden down the bottom here, and you can see that essentially all the patients improved. Different neurosurgeons, so it could be the surgeon, but it could be the device. Preparation was exactly the same. We then actually had one device here, a second device, and then a third. Well, this patient, one device and 2 devices. This patient had one side grafted with one device and one with the other. Whatever the reason for this, whether it was the surgeon, the preparation, or the device, clearly the patients in the UK did not do as well as the 3 patients in Sweden. So 3 patients were grafted in Sweden, 8 in the UK. They started at different baselines. Our patients were more advanced, and they didn't really improve so much as the patients in Sweden. And you can see that down here, that the device seemed to have a difference. So what we would say from this data is that the transplant had to some extent changed the natural history of the treated patient. It had stabilized them to some extent. And on the secondary outcome measures, the things that gave us confidence that this may be a real effect is that the amount of the medication they were taking had reduced. So in the patients who had had the transplant, they were on less medication post-intervention with stabilization of their scores. And that the amount of time when the medication wasn't working, off time, had also improved over time in these patients. And actually, if we wait another 5 years, I suspect that the transplant group will actually improve over the control group. So what we would say to this is that there seemed to be a partial response which related to the site of surgery and either the surgeon or the device or something about the preparation, but we standardized the preparation. What we were also able to demonstrate was on PET imaging that we saw something very similar. So in the Swedish, so this is the PET imaging post-transplant versus pre-transplant. So F-DOPA looks at the amount of dopamine you have in your brain, particularly in the striatum. In the UK cohort, it actually got worse, whereas in the Swedish patient, it actually got better. And one of the advantages you have of this in this study is that this is the overall change in putaminal dopamine loss. So in Parkinson's, you'd expect it to go down. This is the site of greatest dopamine loss in the brain. And you can see this was their baseline. This was before they had the transplant, and this was post-transplant. This was 18 months post-transplant because we couldn't get all the 3-year data because of COVID. There seems to be a stabilization of putaminal dopamine in the same patients in the core date, which we did not transplant. It gets progressively worse, as you would expect. So what we would say is that there's a partial response in these patients that relates to partial dopamine improvement at the graft site. So I would postulate that the reason the patients didn't improve more than we thought is the devices were suboptimal, especially in Cambridge. The amount of tissue we put in was on the cusp of being sufficient to get enough cells to survive, which is what the PET data would say. And there may be other factors about disease stage which we hadn't factored in. But then the question sort of arises, well, why did you not do more in TransEuro? Why did you faff around and only do one partial study? And this is a sort of list of all of the problems that we had in the TransEuro study, which delayed us and stopped us completing the study in the way that we thought. First of all, we had problems with our regulators telling us whether fetal material could be regarded as an advanced therapy. I should stress this is fetal dopamine cells. We have not manipulated this tissue. We've not grown it in culture. We've simply harvested. At the end, they said this was not an ATIM. This was a European study, and how people saw things in Germany, France, Sweden, and England were all very different, which created great problems in trying to harmonize it. These European grants have different partners in. If they change their status, you have to renegotiate the contract. The Human Tissue Authority here changed the regulations with respect to fetal material 3 years into our project, so we had to then produce dossiers, which we hadn't been expecting. The company was helping run this consortium went into liquidation, so the management came back to us, and we had to then manage all of this complex consortium. One of the people who was leading part of our work sadly died of a brain tumor. Another one left his job as one of the major sites for reasons that was never quite clear, but that closed down a whole area and caused a huge distraction to the study. We had problems in Sweden getting permission to use fetal material because the old permit had run out and no one had renewed it. We had problems in the GMP lab where we were preparing the tissue with unexpected breakdowns. There were issues in Sweden around where they could prepare the tissue. Just before we were about to start the trial, we found that the two sites, namely Sweden and the UK, which were doing the transplants, had problems in reproducing how we prepared the tissue, which we had to resolve. As I say, in this hospital in Cambridge, they changed the insurance policy, so we had to build an entirely new instrument based on the one in Sweden, which ultimately I think was not the same as the one in Sweden. We moved to your wonderful system, which you have in the States, EPIC, because it caused such mayhem in the hospital, to migrate the entire paper system over to electronic. The hospital banned or cancelled all elective surgery for months, which obviously had knock-on effects for this type of work. I had great problems with the hospital sterilizing the instrument because it was a new instrument. We didn't have an SOP for it, and that caused problems. And neurosurgical theatres decided that they were going to be refurbished, so they were shut for a large period of time. The junior doctors went on strike about pay. we'd spent so long trying to resolve all these issues that the reagents which we had, for example, the hibernation medium, which we were using in a GMP quality at £130,000, was passing its sell-by date. So we had to revalidate all of that. We had great problems with getting tissue transfer, especially post-Brexit, trying to get fetal tissue from the UK to Sweden to allow them to transplant patients. We had the COVID pandemic that caused mayhem with our follow-up and our imaging. But a fundamental problem, which means that regardless of what we showed in this trial, we were never going to be able to take this forward, was tissue availability. So for the 21 surgeries we did, the 10 bilateral and 1 unilateral, we had another 87 surgeries booked in the hospital that were cancelled because we had insufficient tissue. So in order for this to become a success story, as Tom was suggesting in the title, we had to find another source of cells, which obviously comes from a stem cell source. And so this, you could say, well, why didn't I do this at the beginning when TransEuro came into existence in 2010? And the reason for that was in 2010, there were no protocols in humans that allowed you to make authentic midbrain dopamine cells. It worked in mice, but the development in humans was rather different to that which had been predicted from mice. So I think it's always critical, if you're working on mouse protocols, to make sure that the same applies to humans. But there were these 2 papers that came out in 2011 and 12, one from the group of Lorenz Duda and Vivian Tabar in New York, and the other from Marlin Palmer and Agneta Kirkeby in Lund, that both came up with technologies and protocols which enabled you to reproducibly make midbrain dopamine cells of sufficient likeness or similarity to human fetal nigral cells to allow you to think about moving them forward to a clinical trial. So suddenly in 2011 and 12, we now had an alternative source of cells. These were lab, not GMP protocols that we were using. So clearly work needed to be done to translate that into a GMP protocol, which would be accepted by the regulatory authorities. But early on in this work, we decided that one of the ways to try and maximize the potential for this to translate into the clinic was to form a consortium of all of the international groups that were involved with this. So this involved my group in Cambridge, Marlin Palm, Agneta and Anders Björklund and Ulla Lindvall's group in Sweden, the group from New York, the group from Kyoto in Japan, as well as other groups that were working in the space. The idea being, if we all work together, we could learn from each other and take this forward. And in the early stages, this was hugely successful. It enabled us to learn from each other and exchange information that was not published to try and help us solve some of the problems we had. It also allowed us to some extent to standardize what we're doing, so that whilst the trials, which I'll talk about briefly in a minute, have come to pass, these trials, whilst not being exactly the same, all have a degree of similarity, which allows you to make some comparisons. And essentially, we moved this around to different sites so that everyone felt empowered to contribute to it. I have to say it's become more complicated of late, primarily because all of us are now working very closely with companies, and therefore the ability to share data becomes slightly more tricky under such circumstances. But essentially, the sort of major work that first went to clinic was that of Jun Takahashi groups in Kyoto. As you know, in Japan, they do a lot more non-human work than we tend to do in Europe and possibly in the US. But in this study, Jun showed that by using human iPS cells from patients with Parkinson's disease as well as patients without Parkinson's disease, he could convert them into dopamine cells, and that they worked over a 12-month period in his monkeys with good survival histologically. And that led to him announcing in 2018 that they had started an allogenic iPS transplant trial in patients with Parkinson's disease. I think there are 7 patients grafted. The last patient, last visit in this first in human study from them will be in December, so next month. Their trial will reach its endpoint, and then the data I imagine will be released next year. With respect to our own work, which has really been led preclinically by Marlin, and this again I would say is a very important aspect. Marlin and I work very closely together, Marlin on the preclinical, me on the clinical. She's done some fabulous work with Agneta Kirkeby to demonstrate that these cells actually have the same equivalence to that which you see with human fetal material. So they do transplants of ES-derived dopamine cells and compare it to human fetal tissue to show that they project the same, they have the same clinical benefits, they look the same. And so they've also developed predictive markers, because obviously what you're injecting are precursors to the differentiated dopamine cells, and it's reproducible. So here we have the H9 ES line, the Rosalind cell 17, which is the one we're using in a clinical trial, 3 different batches, one which was cryopreserved, and then a line that was developed in the Karolinska, all of which show reproducible behavioral recovery in this 6-hydroxydopamine model of Parkinson's disease. So over the course of 10 years, we were able to demonstrate, we in the Royal Sense mainly, Marlin and Agneta, that you could reproducibly turn these cells into midbrain dopamine cells. We can do it here, other people can do it. So the protocol is very reliable. You could do it in a way that produced functional recovery in a reproducible way. They seem to have equivalence to human fetal material, which we know, as I've already said, in some cases produces substantial clinical benefits. And what really caught farmers' interest was the fact that this is a very efficient process. So here it only takes 16 days to convert an ES cell into the dopamine precursor, and a 6-well plate of ES cells generates 500 doses. Therefore, if you had a robot and you had 1,000 plates, you'd be able to do 500,000 patients, which is essentially all of the patients you could imagine would need this in Europe in the foreseeable future. And so all of this was published last month in a paper in Cell Stem Cell, which led through the entire preclinical development of this, which was a huge amount of work in order to deliver a cell which is ready for a clinical trial. And that clinical trial began this year. So in February, we grafted our first patient in Lund in Sweden using their device. We waited a month to check there were no major perioperative problems, and their second patient was grafted in March. And then 2 more patients were grafted in September of this year. We will now wait 6 months, and then we will graft 4 more patients, either at the same dose or twice the dose, depending what we see at that period of time. All of the patients are on standard immunotherapy for a year after their transplant, and we do a number of clinical measures as well as imaging measures. And so this is a trial that is being run as an academic study, but we work very closely with Novo Nordisk, who are hoping to develop their own ES-derived cell therapy to run into a clinical trial, which will almost certainly be a global trial. The Japanese group I've already mentioned. There's been a single case study that I'll briefly mention from Mass General and Harvard of an autologous iPS-derived dopamine cell given to patients with moderately advanced Parkinson's disease. The group of Lorenz Studer, they set up their own company, Blue Rock, which is now part of Bayer. They've started their study and released their preliminary results at a meeting. Aspen Neuroscience in California are using an autologous iPS approach and now have FDA permission to start a clinical trial. So this area is very, very active at the moment, and those that have been published already, the one patient that was published in the New England Journal was a patient whose skin cells were converted into iPS cells, into dopamine cells. And what we could say clinically with this patient was that on imaging, there was no real change in the dopamine signal. There was no objective change in their clinical scores, but subjectively, they felt much better. PDQ-39 is a quality of life. So for whatever reason, this patient felt the transplant had definitely helped them, even though objectively there was limited evidence for that. And then in the Blue Rock study, where they published this or had this poster at the movement disorder meeting in August of this year, they used 12 patients who were transplanted every month, 1 a month, at 2 different doses, using an allogeneic ES cell-derived dopamine cell. This is rather small to see. It's 1-year data. We wouldn't expect huge changes. There was some evidence that at the higher dose, there were some improvements in their motor scores, both in terms of the UPDRS, which I've already mentioned. The Hauser diary is a way people have of scoring their motor performance, and there was a subtle change on imaging. So I think the important message from these trials, which have sort of appeared in this preliminary form today, is it seems safe, and there may be some signal of efficacy, but it's a bit too soon to say. And so just the final thing is, where does the field see itself going? Well, obviously, there are these trials which we have to play out and see whether they're really going to work. I think it's going to take quite a bit of fine-tuning and manipulation to make these therapies work consistently with a size of effect that's going to make them competitive. Other people are now thinking about whether we can go beyond this and use direct in situ reprogramming. The idea here obviously being to convert 200,000 astrocytes in the striatum to turn into dopamine cells. There have been various claims for this. There have been problems with leakage of reporter genes. So at the moment, whilst it's an interesting idea, that is yet to prove effective. People are now thinking about combining therapies. So could we use growth factors and cells to try and promote the survival of the cells and their innovation? So this is particularly work left by Lachlan Thompson and Claire Parrish in Australia, showing that actually using this combined approach may have some advantages. And then finally, obviously the use of an ESL enables you to go down the line of gene editing. One possibility would be to knock out alpha-synuclein in your stem cells, alpha-synuclein being the protein that aggregates in Parkinson's disease. In these fetal transplants, there has been evidence of alpha-synuclein aggregation in the fetal dopamine cells, raising concerns that the transplant will succumb to the disease process, but which it probably will, but at least in those cases, it will probably take 40 odd years, by which time the patient would have died of something else. But people are thinking about knocking out alpha-synuclein. And then alternatively, and this is some work we've been doing ourselves recently, is to try and make the cells less immunogenic, to remove the need for the patient to take immunosuppressive therapy, which I'm sure you're very familiar with. So we've been looking at an MHC class 1 to make sure that the cells, once they've had this knocked out, behave in a way which makes them suitable, because MHC class 1, at least in some developmental studies, is important for normal development synaptic formation. And so there is a risk that if you knock this out in your transplanted cells, they won't be able to integrate in the way that they could if they had this present. I'm not sure this is how necessary this is, because we know from fetal material long-term survival can occur in the absence of immunotherapy once you get beyond a certain critical period. So to conclude, I would say the rationale for what we're doing with dopamine cells is clear, and we need to replace 250,000 ideally A9 midbrain dopamine cells to make a difference in Parkinson's disease. So I would say in the eye or the visual system, you need to be sure that the rationale for what you're doing is clear and logical. And that's not always the case, I'm not saying in the eye, but in many stem cell therapies, especially around mesenchymal stem cells. It's been shown preclinically using human fetal midbrain cells and human pluripotent-derived dopamine cells that you can get very good restoration and survival. And I think it's important to show that this is robust, and that it's very important when you're starting on this work to make clear links between the lab and the clinic, rather than arrive with a therapy which you then want to take to the clinic. In human fetal dopamine cell transplant trials, I think there's been proof of principle, but there have also been side effects. We tried to answer that by going to TransEuro, and that proved to be not a viable way forward because of tissue supply. But I would always empower people to critically appraise trials and to try and work out why things might not have worked, rather than always try and say why they should work and whether there's some signal of benefit. I think it's good to be very critical of one's own work and the trials that are out there. Obviously, new stem cell dopamine cells have begun to be trialed. Big pharma's involved. That creates some tensions about timelines, but it does give you the investment you need to take this forward. As you can see in TransEuro, you have to be patient and persistent. And I would advocate working together as an international consortia before you get too heavily involved with pharma, and that before you do anything, it's very clear to articulate what it is you're trying to do and why you're trying to do it, and have a position of equipoise that it may not work, but these are the reasons why I think it would work. And in the Parkinson space, there's obviously a whole series of other approaches that people are pursuing. But what we would advocate with this is that it's not to the exclusion of other therapies, but may complement other approaches that people are taking. So finally, I'd just like to thank all the people who've helped in this fantastic journey we've had over many years. This is the lab retreat with the group, my group, and Caroline Williams-Gray, who works in Parkinson's, who works here with me, and also all of our funders. And this is the fantastic Lund team and our own team in Cambridge that have forged the STEM-BD trial. And with that, I will finish, stop sharing, and happily take any questions.
Fantastic. Thank you so much. I mean, that's such an interesting few decades that the field has gone through. And I, see a lot of parallels in what we have achieved so far and some of the concerns and thoughts that I think have been expressed within the group for where we may be going in the future. I have a whole bunch of questions, but is there anyone else that wants to start us off, or should I begin?
There's something in the chat.
Ah,
That would be me.
go for it. Yeah, Diane, please.
All right.
Go ahead.
Yeah, so I'm with Bright Focus, and as you might know, we fund glaucoma, macular degeneration, and Alzheimer's. And so I guess the question I'm going to ask you is, I found it very interesting. I mean, of course, there were a lot of things that might have, as you pointed out, contributed to it not working in the first round, or not meeting the primary endpoints at least. But I found it very interesting that similar to a lot of early trials of drugs or whatnot, in the Alzheimer's field, they basically thought that it was due to they were treating people too late in the disease. And then in the second round, you enrolled people, and maybe it was a little bit better. But so I guess for us, like timing in the glaucoma field, right? Very important. So are there any lessons that you can tell us about timing and clinical trial design? And if you just have to say whatever you discover along the way. I mean, I think we do have a consortium together. Tom has brought a lot of people together. So is there something that we as a consortium should be focusing on to try and make sure that the clinical trial ultimately, or trials get planned?
Yeah, can I just interject one thing, just because I think that's a great question, and I want to put a specific point on it that relates to the work we're doing. We've thought that patients with milder disease may have a better protoplasm, better microenvironment for the survival and engraftment of RJCs, and yet from a safety and clinical trial standpoint, we're concerned that they have a lot more to lose. And so we're trying to balance, do we want to transplant people with end stage disease who may have less efficacy but less to lose, or people with early stage disease? So how did you guys navigate that? Because you did point out that some of these patients had surgically induced dyskinesias and things.
Yeah. So I mean, the advantage you have is you've got two of them. You've got two.
That's true.
So
Yep.
so you can always argue to the ethics board or whoever that if you think you've got your optimal group, we're only going to
losing binocular vision is not a nice thing, though.
No, it's not a nice thing.
Lose ability to drive.
So you're absolutely right. So in our therapy, in some ways, it's relatively easier, because what we're trying to do is we're trying to restore dopamine. And if you've lost 10% of your cells, or you've lost 90% of your cells, we're still trying to replace them, and it probably won't make that much difference. And by the time you present, you've already lost 50% of them, and that's what we're trying to put back. So in some ways, even if you went later in the disease course, it probably wouldn't matter. Now, my argument would be, ultimately, this therapy is best used as first-line treatment if it works, because it stops people taking all the drugs and all the complications that come thereafter. Now, obviously, if I go to an ethics board or an IRB and say that's what I want to do, they'll just say, right, well, get on your bike. I mean, you're not going to do that. And so, but similarly, if they say, well, you want to go for people like cancer, they failed everything else, they're at the end of the road. I mean, they wouldn't survive the operation. Trying to get a benefit from people who have many other problems is an issue. So I think what you have to do is you have to argue who you think your optimal group and why that is, being cognizant of the fact that the ethics board are going to err on the side of caution. So interestingly, when I've had discussions with the FDA or my colleagues in the States, the FDA are much keener on people being more advanced than they are in other places. So in the Blue Rock study, the patients were more advanced in New York than they were in Toronto, because the Canadian regulators were more open to be persuaded that you could go earlier in the disease course. So I think if you've got good arguments, so I think one of the arguments you can say is, you say, well, you should be going in people with end stage disease. I would say I mean, I don't know enough about eyes, but if I said the network's degenerated, I'm trying to repair a system that's gone and it's not going to connect to anything, I think it's unethical to expose people to experimental therapy for which I have no expectation that it could work, because we've missed the critical window by which to go. You could say the optimal group are the patients in the very early stages, but I think, for your first studies, you're going to have to go for some point in between.
So
So
you're
in
saying
my
it's a
experience,
Goldilocks problem?
it is, but I think the most important thing, what I mean, the FDA, dare I say it, less than perhaps the MHRA here, they're open to discussion because this is all new. I think they're open to hear why you think you should be choosing this group of patients. I think what they object to is you say, I'm going to do this group of patients. And you don't really, you say, it's just going to work. It's going to work in this group. That's what I need to do, without sort of saying, I understand this, I understand that. So I think giving the arguments as to why you think this is the optimal group, and then accepting the fact you may have to go slightly more than that, but also saying, I'm not prepared to treat people with end-stage disease because I think that's not ethical.
Well, and I don't want to just a follow up. So I think that one of the things that was cool about I think it was lecanemab, whatever that with the IV antibody treatment that was approved, the latest one, they actually enrolled people with comorbidities in that, and they were successful. So that's also something to consider. You don't necessarily have to exclude people who have comorbidities. But anyways, I'll let other
And I think
people ask
also
questions.
depends what you're trying to do. So for us, we're trying to restore a network that's gone. If you're trying to stop a disease process, so for example, growth factor epoxies, one of the big reasons they've all failed is they're trying to put fertilizer onto a field that's got no seed in it. It's all gone. So I mean, if you're trying to restore a network, and obviously the amyloid antibodies are trying to stop the disease evolving, you have to go earlier. So again, if you have a good rationale for why your therapy should be used earlier in the disease course, because it's working to stop downstream degeneration, then I think, again, that's a strong argument you can put forward.
And Tom, there's another question from Mohammed in the chat.
Oh, yeah. Mohammed, are you on? Do you want to just ask it? Maybe he doesn't have a microphone. So he said, thank you for your inspiring presentation. I was wondering if the pars compacta or pars reticulata or both of them were considered for transplantation. Also, were transplantations performed bilaterally?
Yeah, so it's a good question. So the group in Halifax, Nova Scotia, Ivor Mendes, he did do transplants of fetal material into the midbrain. I would guess they went into the nigra and into the striatum. So he did both sides. And his patients did rather well, but the question is, did they do any better for having transplants in those two sites? The problem with transplanting into the compactor is it's a long way from there to the striatum, and can the fibers grow sufficiently up to that target site, innervate in sufficient density to mediate that? So that's unclear, but at the moment people are going where the dopamine cells work, which is in the striatum, or dopamine works. Were the transplants done bilaterally? With the fetal material, they weren't, but that's not because for any surgical reasons. We just didn't have sufficient material. It was argued that if we had got sufficient fetal material, would have done both sides at the same time. And with stem cells, obviously, we do have. So in the STEM PD trial, the patients have, I think it's about an 8 or 10 hour bilateral operation. So both sides are done at the same time.
Great. If anyone else has any questions, feel free to either put them in the chat or raise your hand. I wanted to ask a question. One of the major things that the retinal ganglion cell transplantation field is dealing with right now is rather poor survival of their neuronal grafts. I think among the several laboratories that have published on this, it seems like less than 1% of the total cells that are transplanted into the eye survive for more than a few weeks. And we're trying to figure out what are all the various factors that contribute to that. So I was wondering first, if you could tell us a little bit, you told us what you need to achieve as far as 200 to 250,000 A9 dopaminergic neurons. How many do you actually transplant in order to expect to achieve the survival of those cells? And then what sorts of factors do you think are undermining the long-term survival, and what approaches is the field? You talked a little bit about MHC, so MHC compatibility. So I think immunomodulation, reactivity is one thing. Growth factor support is one thing. But so what are the
it's a good question, Tom. I mean, we get a better survival, but I mean it's not crackerjack. I mean, we get about 5 or 10%. So we graft. So one of the advantages with what we've done in STEMPeDILI is that the cell product we've got, which we're putting into patients, is also the very same cell product we've used in the lab. So it's all cryopreserved. So you have to infer that the survival you see in rats can be extrapolated to the human brain. But we put in between I think 3 and 7 million cells, depending. So first dose is about 3.5 million. The second one will be 7 million to get about 200,000 surviving cells. So it's just less than 10%, somewhere between 5 and 10%. So the survival is very poor. But for us, that's less of an issue because ultimately the surviving population is relatively small. Now, I mean, you could argue, because I don't know how many retinal ganglion cells are, but I bet there are not that many. That you could argue, because we're not talking about millions and millions. You could say, well, even if I get 1% survival and I need 500,000 of these, whilst I'm putting in 50 million, in the great scheme of things, that might not be the biggest number in the world. So you could just say, I don't really care that so few survive. I'm just going to put in more starting material.
Yeah.
Now, as to what drives that, I don't know. I mean, obviously, if I was a cell being grafted, it's a pretty stressful experience. I mean, you've got to be prepared. First, we've got to be woken up from a frozen state, which I think compromises them. I mean, we've shown that it doesn't significantly compromise them, but they're never as good as fresh tissue. Then you obviously have to load them into a device to deliver them, and you're putting it into a pretty ischemic hypoxic environment, regardless of what that looks like, because you're obviously sticking a needle in, generally speaking, and injuring the site where you're implanting the cells. The other thing which we started to do, which was a bit of a shock, if I'm quite honest, was on a separate project, we've been quite interested in inflammation in the brain and what drives that. So we've been doing single nuclear RNA sequencing work in the post-mortem brain, and we had these various sites, and I said, just take the putamen as a control area, because, I mean, it'd be interesting because we stick dopamine cells there and it's pretty quiet, and found out that area is pretty inflamed in Parkinson's disease. So I think understanding what your host... So I suppose what that told me was that the disease, whatever disease you're treating, you need to know what it's doing at the site where you're putting the cells in a way that I think we'd slightly underestimated. So I think we'd assume that all of the problems were relating to tissue prep and the injection process, which I agree with. But I think knowing more about your disease state, where you're putting them, and how that may compromise your cells is also important to know. So obviously for us, inflammation is an issue, but we give immunotherapy. So it probably damps it down. But I think it is a problem, and people have obviously tried this, antioxidants, growth factors, putting them in with your cells. The trouble is, the more you manipulate these things, the more problems it creates with regulators.
Yeah. Great. Another question I had, you talked a little bit briefly about the fact that you need dopamine there, but there's sort of a difference between cells that just pump out dopamine versus integrating into like circuits or forming synapses where it's given in a regulated or specific manner. And that may be one area in which our two approaches or two challenges diverge a little bit, because for ganglion cells, obviously, the wiring is going to be absolutely critical to their ability to function correctly. So I was wondering if you could just tell us a little bit more about the preclinical, or if there's any post-mortem human tissue in what kind of circuits or synapses these things form, or what controls that, or how you can...
Yeah, I mean, it's a good question. I think what's extraordinary is that if you make the right cells, they seem to know what to do. So obviously, a ganglion cell having to make an axon that's got to go a long way.
Yeah.
I mean, I mean, I don't know how it would do it, but one of the ways in which Marlin, for example, has tried to look at the axonal outgrowth from her ES-derived dopamine cells is to transplant them into the rat nigra. Not because we're trying to recreate the nigral striatal circuit as a way of treating patients, but to see whether those cells could grow to the striatum, which is about a centimetre or so. Which would be sufficient in a human to innervate the putamen. And what you find that's curious about these things is if you transplant these cells in, they grow axons to the striatum. They don't grow axons to the thalamus or other areas of the brain. So the dopamine cells which differentiate out of that produce axons, and for whatever reason, they know where they're going, even in the rat brain. So there's something about their ability to pick up signals in the striatum which enables them to do that. And I mean, I've just been writing a review with Anders Bjorklund on cholinergic transplants to the sort of the hippocampal, and he was citing a paper in that where in the 1980s they transplanted in, you know, basal forebrain cholinergic neurons, striatal cholinergic interneurons, and brainstem cholinergic neurons, and the only one that innervated the hippocampus anything like normally were basal forebrain cholinergic neurons, the ones that normally do it. So just having cholinergic cells of any type, in the same way as if you have A10 dopamine cells, they do not do what A9 do. So I guess for you, if you could produce retinal ganglion cells that are the real McCoy, one might anticipate that they would actually just grow their axons to their normal site in the brainstem and such like. So it seems, I mean, I don't know, but it seems if you make the right cell seems to know what to do.
Interesting. That's encouraging.
Yeah.
Now you mentioned though that you're transplanting neuronal precursors, right? These aren't fully mature A9 dopaminergic neurons? Can you tell me a little bit about that? Have both been tried and precursors do better, or how do you know sort of what stage of maturity is optimal for your system?
Yeah, we don't know is the honest answer to that.
Okay.
So what we could say from fetal material was that if you take tissue which is you know, you've got mature neurons and then you harvest them, you basically exotomize them, and then you transplant those, they're not happy, not surprisingly, so they die off. So we've known that for years, and with human fetal material, people have used, you know, late fetal material, 10, 12, even second trimester material, and it never survives. And so that's always thought to be due to exotomy and getting cells at the point at which they're sort of destined to become dopamine cells, but aren't there yet. So that we think is an important feature of it. Now, what do we know about pluripotent stem cell derived dopamine cells? People have different differentiation protocols, and people who've gone beyond 16 days, so gone to 21, 25 day protocols, their transplants never look very good, or they don't look as good. So it seems that if you allow the cells to mature further in culture to a point where they perhaps are more committed and becoming dopamine neurons, they survive less well. So the sweet spot, coming back to that, we were discussing earlier about the patient, is the exact time at which you think your cell has got no choice but to become a dopamine cell, but is also, not too primitive, it could go anywhere, but not too advanced that you exotomize it, and therefore you reduce it. So it's difficult to know exactly when that is. And obviously one of the things that Agneta particularly spent a lot of time doing was trying to come up with markers in culture, or FACS markers, which are predictive of where your transplant will go in 6 months' time. Because these are essentially prodrugs. We put the cell in, and in rat models, they take 5 to 6 months before they have a functional benefit. And what we wanted was to have markers in the dish that when we harvest our day 16 precursors, we have a batch of markers which are predictive of them becoming dopamine midbrain neurons 6 months later. So I think that's an important thing which the regulators like, and it's also gives you great reassurance that if you're, especially when you start making more batches of these things, that each batch is the same as the last one in terms of its having these same markers.
Great. Quiet group today. Anyone else with any questions? I've still got more, but oh, good. Brent.
Brent.
And
hi, I'm Brent Young from Jeff Goldberg's lab at Stanford. So you mentioned that the device, you had to recreate the device to do your clinical trials. Did you ever determine what was the major difference between yours and the Sweden device that was the difference maker, or is that still unclear?
I think everything was wrong with it. I mean, I'm not the neurosurgeon. You wouldn't want me to do neurosurgery even on a good day. I'm a neurologist, but I mean, I think what that taught me was that this sort of, because the device is quite simple. I mean, it's basically just a needle. You're injecting things. It's just small volumes that you're injecting. So you wouldn't think it was that difficult. But actually, I mean, you know, the devil is in the detail already. You know, I think, so first of all, they had problems. I mean, I'll never forget the first one I got out of the package. I couldn't actually move it because they glued the plunger in. Then the next one I got out, it just fell straight out the bottom. of the needle, and you sort of think, well, this is not great. So we had to go back and fiddle with it. But it's just, I don't think it had the fidelity to, I think the end of the needle was probably a bit sharper than it should be. So I suspect it killed cells as they went in. I'm not sure how accurate it was. And the mistake I made was that I assumed that the making of a device was relatively straightforward because it was copying something that had gone before. And so we did no testing on this. Essentially, we just assumed if we could, I mean, we showed that we could get a few microliters out, but we never tested the viability of the cells that were coming out of it. We never used it in any animals before we actually went into patients. And that, I think, was a mistake on my part, that actually we should have been more rigorous about that. And it is a big area in our field because, in ophthalmology, you've got all sorts of, people love gadgetry in the eyes and all sorts of devices for squirting things in and recording and doing all sorts of things. So you've probably got all sorts of devices, but I would tell you it's absolutely imperative to make sure that your cells are compatible with the device, and don't just assume that they are because the device has been used to put things in the retina before, VEGF or whatever. You need to make sure it's compatible with the device. And, I know companies have spent 8 figures on trying to build devices to deliver these cells, which you think would be ridiculous. You think it would cost nothing, but actually making devices, because there is no device which is currently available for delivering cells to the brain. So in your field, I would say it's absolutely essential to make sure that whatever you put your cells in are compatible. Whatever you put your cells in, they're compatible with those cells, and you don't compromise them. Because coming back to Tom's point, if only 1% of your cells survive, and this compromises them by another 50%, you're only getting 0.5, and so and you could see in Transura, we dropped below a threshold to have significant. I think we still have something, but it's clearly we've messed up somewhere in delivering them, I think.
And just jumping off of what Brent was saying. So do you think that was the major reason why the surgery between Sweden and UK were so different? Or was there did they have the same instructions or protocol, or do you think there needed to be a little bit more checklists or more coordination?
I think we try to coordinate it as much as possible. So the surgeon we used here in Cambridge, does a lot of deep brain stimulation. So I mean, he's a very experienced stereotactic neurosurgeon. He's obviously done no transplants before, and the neurosurgeon in Sweden had similarly not done any transplants before, and is a very accomplished stereotactic neurosurgeon. He probably, if I'm honest, he's more interested in the science and so he's been heavily involved with the device for STEM PD and such like. So there probably could have been some surgical differences. We tried to standardize the protocol as much as we could. I mean, the structure we're trying to hit is quite big, so it's not particularly technically difficult in that sense. They use the same sort of approaches, with the frame and planning before they did it. They compared notes because we had one patient where we had problem localizing the SIT cells, missed the target. So they spent ages going through that together. So there was a lot of coordination between it, but you obviously I've no idea.
It's 10 years later, so maybe there could be more like Zoom or whatever.
And so what we do now is with our STEM PD is that they liaise with every single patient. But I think the fundamental difference was that the devices were clearly different.
And the interesting thing, coming from a biochemistry background, I know I would have to use polypropylene instead of polystyrene because my protein would stick to that styrene plastic and not the other. So I don't know, was there a coating on the those cells obviously have ECM and whatnot. So did you coat the device?
But as far as I know, we didn't. But what I would say is, I think, coming back to the point I made earlier, superficially these devices look the same, but they clearly weren't.
Yeah.
And I think, and so the problem, and so other groups, so for example the New York group, as far as I know, they've used a ClearPoint system for delivering. So they do intraoperative MRI to show where they're putting the cells. Well, that system, is very good for delivering chemotherapy to cancers in brains and things like that, but it's never been used for cells. So again, I'm sure it's fine for the cells, but I don't know that.
Get the coordination at the beginning so that the regulatory people are on on board from the outset, I guess.
And it's also a bit boring. So, but the problem is, if you invest years of science into making the best cells in the world, and then someone squirts them in with something which kills them. I mean, that will kill your program, and there's nothing wrong with the science. It's all about delivery, and so it is. I think it's a slightly neglected area.
Yeah, absolutely. This is fantastic. I want to end with one final area of discussion, and that is, something that is in the future for us. We're clearly in the preclinical stages now, working out how these stem cell transplants behave in animal models. But I think in the future, when it comes time to start thinking about clinical trials, it is clear that funding, but also industry, I think, is important, industry partnerships. And you had alluded to some challenges that invokes when you're talking about large collaborative groups. But I'm also kind of interested in knowing, the industry members are going to be necessary for developing things like the techniques and the tools to do these transplants. At what point within the preclinical stages did you find that industry became interested and seeing this as a viable approach that would go towards clinical translation and clinical trial? And when did you start those interactions, and how did that go?
Yeah, so it's a very good question, and I don't really know the right answer to it. So I would say the advantage of obviously having pharma investment is when things go wrong and you suddenly need a lot of money and input, they're fantastic. So for us, all the CMC, Novo were just fantastic. I mean, they just have such expertise, and then you suddenly have to buy a buffer at, goodness knows how many hundreds of thousands of pounds, euros, dollars, doesn't matter when it's up at that price. You simply couldn't, and you go to a charity and say, could you give me $500,000 to buy, 5 milliliters or something, so they're fantastic. They have the expertise and they have the financial support. The downside is, of course, they're driven, their programs may stop tomorrow for reasons that you don't know. And secondly, they obviously have a speed of turnaround, which they're very keen on. And for us, cells take 5 years. Well, if I say I'm going to do 1 dose of cells, wait 5 years and see what happens, you can imagine what the company thinks of that. So those are the advantages and the tension between it. I think what's quite useful is to make sure in your own mind that you're pretty close to going to where you want to go in the clinic, and that you have some ownership of what it is you want to do with that. So for us, I mean, it was more fortuitous than anything else. So in the Blue Rock case, as far as I know, Lorenz and Vivian had funding from NY STEM. That was coming to an end. They weren't going to get funding from NIH, I think, to take this forward into the next stage. I think in part because, Trump was around and all sorts of things. So they decided to set up a company and get investment. And that then gave them obviously quite a degree of freedom, but they were obviously so they decided once they'd really got to the end of it that they would get investment and take it from there. And obviously Bayer now are involved with it, or they leave them to plan their own work. In our case, it was more by chance. We were seeking to develop up the therapy and then look for a commercial partner, and the commercial partner came and found us simply through a casual conversation. And then what I found quite interesting was it's all around IP, which again, you're much more on top of than we are here. And of course, it's different in this country. So in my case, the university owns the IP. In Sweden, the individual owns the IP. So I think to get industry on board, I think what's quite useful is to be clear in your own mind. Think I'm pretty close now. I've got this up to I know what I'm doing. I can make these things. My GMP protocol looks pretty good. I'm thinking of a clinical trial. I already know who I want to work with this. Now I would quite like someone to come and fund my clinical trial. And then the key thing is to make sure that you have some say on who they use for their advisors. Because one of the problems is the people, I don't know what it's like in the world of eyes, but some of the people who are very well known and eminent movement disorder specialists don't know anything about cells. And so their approach to trials are based on drugs or other interventions or neurosurgery. And therefore what they say is not necessarily right or helpful. But the company relies on that because that's what they've been told. And then you end up this slightly difficult conversations trying to persuade them that actually their expert advisors might not be as expert as they think. But I think so at one point in my life, you think this was all something you should never do. But to be honest with you, if you haven't got investment from pharma, you're going to go nowhere with this. Right. Because these trials cost millions. And if it's ever going to become a market therapy, then someone's going to have to take it all away.
Yeah, exactly. Wonderful. Well, thank you so much. This has been a really interesting conversation. It's beautiful to see how this work has progressed over the decades, and congratulations on getting it this far. Best of luck in the trial. I hope the patients do wonderfully, and most of all, just thank you for sharing. I appreciate
Thank
it.
you very much for inviting me.
Wonderful.
Okay.
Thank you.
Take care.
Thanks,
Bye.
everyone.
Bye-bye now.
Bye-bye.